This is QD Clinic. I am Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.Live, March 18 and 19 in Dallas, Texas, or virtual from home. Great meetings like this are attended by great rheumatologists like you. Today's case is, what are your options with VTE? A 64-year-old female with seropositive RA presents with shortness of breath, chest pain, going on for 2 days. She's highly seropositive, taking methotrexate 20 a week, tofacitinib 11 a day, prednisone 10 a day, aspirin 81 a day. She's on an Alupent inhaler. She's admitted to the hospital from the emergency room because she has acute shortness of breath and ankle edema. She's got a low PO2 and felt to be at high risk for pulmonary embolism. On spiral CT, she does have an embolus, and you have to treat her. Now, again, what are her other medical problems? Hypertension, obesity. She's multiparous. She's had 5 babies, lost one to a spontaneous miscarriage. No prior history of MI, CHF, CVA, DVT, or PE. She's had a lot of DMARD treatment in the past, multiple TNF inhibitors, leflunomide, hydroxychloroquine. When she's admitted, she has 5 tender joints, 4 swollen joints. She has rheumatoid nodules, and she has some edema about the ankle. The question is she having a pulmonary embolism? She is, and why is she having it? Is she having it because she's overweight? Is she having it because she's multiparous? Is she having it because she has RA? Is she having it because she's active RA? Is she having it because she's on steroids or because she's on the JAK inhibitor? I think you need to know the numbers to understand the risk. Clearly, she's going to get treated, and she's going to get anticoagulated and then sent home on anticoagulation for 3 to 6 months. This is her first episode. The population risk, those people who are running around outside in the mall or wherever, their risk of developing a VTE, venous thromboembolic event, either a DVT or a PE, is about 1 to 2 VTEs per 1,000 patient years. An RA patient is about a 3 to 4 per 1,000 patient years. An RA patient with disease activity, because inflammation substantially increases risk, could be like 4 to 7 per 1,000 patient years. An RA patient on a JAK inhibitor, usually with active disease enough to get on a JAK inhibitor, has a rate of about 5 to 8 per 1,000 patient years. So despite all this craziness, especially from the oral surveillance study, the actual increase afforded by the JAK inhibitor is about 1 or 2 more cases per 1,000 patient years over and above RA. So RA is the bad player, activity is the bad player, and tofacitinib, baricitinib, and upadacitinib are contributory elements that you may have to manage. So how do you manage all this? Well, if you have an RA patient who has got a prior history of a VTE, you probably shouldn't start them on a JAK. You've got other options, do you not? And there are other risk factors that would contribute to the risk of VTE. Age and obesity are big ones, right? Prior, and then the other one being prior VTE events is you're more likely to get it again. That's why you would want to avoid the JAK inhibitor, which might increase the risk. If someone is on a JAK inhibitor and doing well, and has not had yet a VTE, and you're worried about the oral surveillance data, do you stop the JAK inhibitor? I wouldn't. I'd have the discussion with the patient, find out if they've ever had a VTE, and if they're ultimately, severely worried about it because someone in their family died of a pulmonary embolism and they don't want to be that person, you have other options that you would have to consider switching to. Again, you have to assess VTE risk in your RA patients as you give them therapy. Interestingly, this risk of VTE has not been necessarily ascribed to the hematologic drugs like ruxolitinib and other ones, but they are now mentioned in the new JAK inhibitors are approved for eczema or atopic dermatitis. So this is something that you're going to have to deal with. And again, what I would do in a patient like this is I probably would stop the JAK inhibitor. because she's going to have to stop because she's in the hospital anyway. I continue her other medicines. I put her on anticoagulation. As soon as she's home, I would put her on another DMARD, another biologic. Again, what are your options? They're really contingent upon the therapy she took. She's taken methotrexate, hydroxychloroquine, leflunomide, etanercept, and adalimumab. You haven't done IL-6 inhibitors, IL-1 inhibitors, abatacept, or rituximab in this patient. And I think that she now, because of her RA, her active RA, and her prior history of a VTE event, and she's also overweight, she's at risk for future VTEs. You try to minimize it with drugs that are not known to give you that association. Hope you managed it in a similar manner. We'll see you at RheumNow.Live, either online or in Dallas, March 18 and 19. Take care.